I am Dr. Laurel Barr. I am here today with the Early Career Physician section, formerly Young Physician section. I am here to talk about the Sports Medicine section. I'm here with Dr. John Kiel, who is the chair of the Sports Medicine section. And thank you so much for being here today. Tell me a little bit about yourself and how you got involved and what the section is doing and what drew you to it.
Yeah, so thanks for having me. Again, I'm John Kiel. I am currently at USF in Tampa. I'm one of the APDs here at the USF Tampa General Emergency Medicine Residency Program. I do a split practice between emergency medicine and sports with some of the local collegiate and professional teams. Before I came here, I was at UF in Jacksonville in their residency program, and then going backwards from there, I did fellowship at Kentucky and residency in Buffalo, New York. And so I've sort of circuitously made my way to the Sunshine State. Having
That is
grown up,
how it happens,
yeah,
doesn't it?
yeah, having grown up in Maine, it's you get the warm weather bug, and it's hard to go back to Four Seasons. As much as I miss it, it's 60 degrees out here and probably 25 degrees in my hometown.
And I'm in Ohio where it's spring break
Yeah.
and it's 30 degrees and
Yeah.
it's cloudy. So I'm sure you really do miss the four seasons almost
Yeah.
as much as I do.
Yeah, exactly. Okay, so that's where I am. I'm here in Tampa, and I'm glad to join you guys. As far as your other question was, how did I get started with ACEP?
Yeah, and the sports medicine section.
So, sports medicine isn't new, but we are new-ish, and we are certainly one of the smaller sections, both at ACEP and within the sports medicine community. EM makes up a small sliver of the sort of total primary care sports medicine pie. So I think most residents that are interested in sports have to find a mentor if they can. I think a lot of the success comes from somebody sort of walking you through their footsteps and how they got to where they are. And so I was fortunate enough when I was a resident to find a few mentors through EMRA and I think ASAP, although to be honest, it's been a decade. I'm not 100% sure. And they were just sort of gave me their advice. And, I was able to set up a sports med rotation when I was a resident and go through the match process and successfully match. And a lot of that has to do with just interest in sports, but also being very deliberate about your goals, right? And so you come out of fellowship, and I think, folks want to do 100% sports, some want to do 100% EM, most probably want to do a little bit of both. There's some logistical challenges to that, sort of as far as like who employs you. It's a lot easier at a university where you can sort of slide back and forth, but if you're in private practice, it's a little trickier. And so, but my goal was to be in academics. And so I was able to get a job at UF Jacksonville for 5 years out of residency and do a split practice there and have a core faculty role and be involved in their uh, GME. And then I came down here to sort of take on that same role. But now that I have a few more gray hairs and people have accused me of being mid-career, which I take in stride but with a skeptical eye, and take on a more of a leadership role in this residency program. And then at the same time, we're sort of building out our sports medicine section of emergency medicine in tandem with family medicine, who's been here for 25 years. So we're very new. They've been kind enough to sort of let us play in the sandbox with them, and we're sort of unpacking what that's going to look like, sort of or in real time. We're sort of working on that now, but we've like successfully submitted a application to the GMAC at the hospital to get funding and approved for another fellowship slot through emergency medicine that will go in tandem with the two family medicine slots that already exist. And so we're doing some cool stuff here at USF, and I'm glad to be a part of it.
So very cool, very different expanding field. EM's a little niche in it. I imagine this is kind of like where we are in sports medicine is where emergency medicine was maybe 30, 40 years ago, where it's the wild, wild west, but we're gaining footing and telling everybody why we have a great reason to be there and then becoming leaders in the field and expanding our presence.
Yeah, actually, the AMSSM elections were just the last month or two, and a guy named Dave Burkhoff, who was an ER doctor at UN at Duke, was just elected as like the second president-elect or something like that. He's going to be the first president of MSSM in a few years that's an ER physician. So we are certainly establishing our footprint there. historically it's almost all family medicine. And then of course, pediatrics and physiatry, and to a lesser extent, internal medicine and us have also realized, hey, we can do this too. And we've slowly sort of built a footprint in the larger sort of family medicine pie, at least historically. And so everybody's sort of gaining, I guess you could say, and that pie is getting bigger. And emergency medicine, we're part of that. But it is there's a little bit of politics to it and a little bit of territorialism, and I think everybody's justified in their own way in having that opinion. But the good news is, I think we have a skill set that nobody else has, and that's undeniable. And so, being on the sideline for any emergency, whether it's orthopedic or otherwise, we're unquestionably the most qualified person to handle it. So I think we immediately have our niche there. And so most places are accepting of having an ear doctor on the sideline. And just as an example, when Damar Hamlin arrested in Cincinnati a couple of years ago, serendipitously, Cincinnati has a lot of sports, EM sports, and they had a couple of ER doctors on the sideline, and he had a great outcome because the guys on the sideline have done that a million times, and they knew exactly what to do. And I think that was a real highlight of the importance of having emergency medicine and why we are, sort of slowly becoming bigger leaders in the sports med community.
Yeah, certainly a great example of why we are best positioned to be there.
Yeah.
And also one of those things where I actually love doing event medicine. I've gotten involved in a couple of events here in Columbus, including we have the Arnold Schwarzenegger National Weightlifting Competition. It's called
Mhm.
something, Arnold Sports Fest or whatever. But
The
I've
Arnold
gotten
Classic. I've been
that
there.
the
Yeah.
art. See, you know better than I do.
I've been there.
But it was awesome because I get to be there in case something real bad happens. And then otherwise, the athletic trainers, I mean, they can take care of the sprains. But
Yeah.
I saw a guy who ruptured his biceps lifting up, or just one bicep lifting up 800 pounds. It was the easiest diagnosis I've ever made. I literally said,
Mhm.
yep, and then let someone do the paperwork. It was awesome.
Mhm. Yeah, yep. That is fun. Yeah, they have USA weightlifting there and a bunch of powerlifting competitions. That's a fun event to cover for sure.
They also have my favorite one is medieval jousting, or it's not jousting, it's medieval fighting. So
Are
they
they
get
on horses or?
they're not on
Oh,
horses, but they have like the old helmets and like wooden shields, and they have swords, and they have like those like sticks with balls on them. It's actually
yeah,
really
yeah.
fun to
So you can
watch.
get hurt. People can get hurt. Yeah.
Well, there's a reason I was there, right?
Yeah. Yeah, that stuff fun. It's so amazing because you can still be like a ER doctor primarily and then get out of the hospital, and there's always a question of compensation and how much you're getting paid to do these things, but it's a very leisurely form of work, and it can be crazy. There are like some really busy, marathons and triathlons, and there's some very famous ones where you get a lot of sick patients, and that can be just as fun as covering the Arlo Classic. It's fantastic to get out of the hospital.
Yeah. And kind of the reason I went into emergency medicine, the same reason I'd be on the events. Like if you don't know what's going to happen, who do you want there?
Yeah.
It's really us.
Yeah, and there's no question. Sports is a little trickier, not trickier, but it can be very nuanced, right? One thing I have to tell my residents when they come to clinic with me is you have to take off your emergency medicine hat, right? Like, okay, the X-ray doesn't show a fracture, that doesn't mean we're done. We're the specialists now. We have to like figure out what tendinopathy or ligament injury or weird, compressive neuropathy they have, or maybe it's just knee arthritis and we have to have a treatment plan. We can't just say follow up with your primary care doctor anymore. We're the guy. We have to do it. So it's fun because you can, do the acute medicine stuff, and then you can also sort of have that skill set of sort of longitudinal management. And oftentimes, not often, sometimes you're sort of like a puzzle that you're trying to solve. And the surgeons love us because, when I send somebody to one of the orthopedic surgeons, the likelihood that they have a surgical problem is probably 4 to 5 of those patients end up in the OR. And so that saves them a lot of time too. So we are a really great sort of cardiologist to cardiothoracic surgeon type relationship where you can take away a lot of the surgical cases from them and or non-surgical cases and then feed them more surgical cases. And we do a lot of cool stuff with MSK ultrasound and procedurally, which makes it fun too.
Yeah, and a whole lot of new tools being added to the toolbox in this specialty, which is awesome.
Yeah, it's kind of the Wild West a little bit. It depends on who you ask. PRP is either going to cure everything or it cures nothing. I think the more pragmatic, objective observer says, yeah, we're optimistic, and there's some literature that it probably helps with some musculoskeletal conditions, but there's also things that it probably doesn't help with it all. And again, it depends on who you ask, right? It's the data's the problem, or you're not giving enough concentration of PRP or whatever. You're not treating them enough times. There's all these different things, but it is very interesting, right? And PRP is just skimming the surface of or platelet-rich plasma, I guess I should say. But there's stem cells and there's autologous chondrocyte plasma and there's I don't even know them all, right? It's crazy how much regenerative medicine and orthobiologics are starting to shape orthopedics, and they're doing that stuff perioperatively too. So it's a very interesting time to be involved. And clinically, I guess just while we're on the subject, for people who choose to do a sports fellowship, some of them just leave emergency medicine entirely. They hang their own shingle and they open up a orthopedics and sports medicine practice, and some of them just do regenerative medicine primarily, and it's fairly lucrative. Yeah, again, depends on who you ask if they're practicing medicine or not, but it's a nice opportunity for those folks to like have their niche and step away from emergency medicine when they're ready to. And um, it's one of many reasons why I think this is a great fellowship choice.
Well, and anytime you tell me about abbreviations I don't know or different things and saying we don't know, is it the data, is it this, that means there's great opportunity for contributions to the field and for
Yeah,
doing your own research and then writing about things and contributing to the section and advancing the section in general. So the mission statement of the section is to advance excellence in sports medicine education, clinical practice, and research within emergency medicine, equipping emergency physicians to care for athletes and active patients across settings.
that's a pretty good mission statement. Um, which one do you want me to tackle?
Tell me about the mission statement and how we contribute to it. And really, this is an active group of patients. This isn't the obstructive sleep apnea that's can't get up. And we got to
Well,
make them keep them that way. So let's
that's
talk
that's
about
a
how we do that.
That's interesting. So there are different types of sports practices. I would say you can think of it like there's non-surgical orthopedic practices, and then there's a true sports practice, right? So like I'm at USF, we have a much more sports-oriented practice with younger, healthier patient population. But when I was in Jacksonville, we were at a county hospital. Everybody I saw was over the age of 40. They all had diabetes, they're all obese, and they all had arthritis, basically. So different
Different
practice
populations.
settings. Yeah, it's very interesting. But I think as far as the mission statement goes, there's a component of education. Most of actually, I think everybody that I know, either through ACEP or through AMSSM, which has, of course, an EM section, I can't name a single person off the top of my head that is not academic. There are a few, I guess, but like the 95% of them are involved in a residency program or a fellowship, right? And so it's sort of self-selecting. I think that the ACEP Sports Med section members are all oriented towards academics. As an example of things that we've done to support that, right, is before my time, but some of the faculty maybe 5 or 10 years ago created those online exam videos, which are fantastic, sort of introduction to the shoulder exam, trying to be more mindful of how you approach a patient, especially for a resident interested in sports who's trying to gear up for a rotation or sort of brush up or learn new skills. We created a sports medicine curriculum guideline for emergency medicine so that if you're either creating a rotation or a longitudinal scholarly track or something like that, there's at least a rough guideline that we put together maybe 5 years ago that helps sort of outline some of the objectives and primary like themes of ultrasound and imaging interpretation and physical exam skills and procedures and things like that. So there's a lot from an educational standpoint. And then I think clinical excellence, the part that I like about that is there's what we do in the emergency medicine, and it's sort of a different flavor, right? Like when somebody checks in the ED with what you assume or deduce to be knee arthritis, you're like, okay, well, it's not an emergency. There's a couple of patients on pressors in my pod. Like, I'm sorry, I can't give you the time that you deserve. But I think with a little bit more education and background, sort of, fellowship training, clinical experience, you can give them more without taking a lot of time, right? So I will often sit down with those patients and say, hey, like, you don't really have a medical emergency. You've tried these things. Here's what I would suggest is next. And also, I work in an orthopedic clinic. We can get you in very quickly. We're going to expedite your follow-up so that you are pointed in the right direction, right? Or you very clearly have a ACL tear. I'm going to order your MRI to be done as an outpatient, and I'm connected with one of the athletic trainers from clinic, and we'll get you into one of our sports surgeons. And so there's some things you can do from the ER side that are really great and helpful. And then on the sports side, like I think you just sort of have your sort of specialty training and your skill set that sort of very different from emergency medicine. I think pairs with it well, but is a different sort of flavor of clinical excellence, and it's nice to do both. Sometimes I will be honest, it feels like it's hard to be excellent at two very different things, but it keeps you on your toes, and you have to make sure you're always on top of learning new things and refreshing old things.
I mean, they may be two different things, the pressor patient and then the ACL tear, but certainly we see plenty of people with musculoskeletal injuries, either wear and tear over the long time or the acute injuries after playing things. So it might feel different, but it is like everything we do, part of the potpourri that is emergency.
Yeah, oh, absolutely. And back to circling back to education and clinical excellence, maybe the overlap in this conversation, but the thing I try to teach my residents the most is like, here are some landmarks for your knee exam. Here are like a few special tests that you should do and why. Here's the times you should use a knee immobilizer, and here's all the times that you shouldn't, right? Here's when you use an air cast versus a walking boot, and who needs crutches, and who needs to see an orthopedic surgeon, who can follow up with their primary. Like there's a lot of nuance to it that I think you can do better, provide better care to your patients. Uh, and so that sort of is a clinical excellence component and the educational component, which is why almost all of us are in academia somewhere.
Well, and you mentioned that a couple times, which makes sense with we're developing the field and then also probably just the work hybrid. It probably makes it easier to do both when you're in that academic
Yeah.
setting. And just at least having those times off that you can get protected for your other activities. So that kind of does lend it, and it's really a great field to be in as far as the academic component. So it lends itself well. Initiatives of the section contributing to the education and creating articles, contributing to programming at National ACEP, supporting research, best practice initiatives, a mentorship program. There's a virtual mentorship program online, sideline event coverage, and then it's just strengthening EM's role in the community.
Yeah, those are all. It sounds so simple when you just say in a sentence, but it's a lot.
I don't think that's simple. That's a whole lot of stuff.
It's a lot. Yeah. Where should we start? Where do you want to start on that? Let me see. Research.
Let's talk about your virtual mentorship program.
Yeah.
Sounds like it's easy to get involved in.
Yes. So that's probably honestly the most important thing. I think that the sports med section does, and I imagine other sections have this too, right? I'm sure critical care and wilderness medicine and stuff. But the idea just being like, if you're at a program, most programs don't have an EM sports person, right? We're lucky that we have a few. We had one where I trained. There was not any in Jacksonville before I got there, right? So there's a lot of residents out there who, A, just like they don't know, right? You don't have the exposure for a variety of different reasons, but mostly there aren't that many EM sports folks. And so if you don't have a mentor because you're at a program or a medical school that doesn't have emergency medicine, sports medicine faculty, then A, you don't may not even know it's an option, which I didn't when I started residency. And B, maybe more importantly, you don't have a mentor. And so the virtual mentor program is totally volunteer, and there's probably 20 or 30 faculty on that spreadsheet that sort of get rotated through by one of the members of the section, and you can sign up on the website very easily. Um, if for anybody who's watching this video in the future, you sign up and you don't get a mentor assigned, it's just a hiccup in the IT side of things, and make sure to reach out to the section directly because we will find you one. And I think this is sort of a self-selecting group of people who want to provide mentorship and are always willing to make ourselves available to a learner, whether it's a med student or a resident, or even somebody who's a few years out from residency and decided they wanted to go back and do a fellowship. And so even if we don't end up being your mentor, we will always make sure that we can find you one for sure. So I think the mentor program has been successful. I had mentors who are still active, and it's weird to say, but I know that I am mentoring people both explicitly and sort of implicitly, and in their own way, they will be mentoring people in the future too, right? It's just part of the job, I think.
Yep, that's a great part about our job. We get to pay it forward.
Yep, exactly.
So if someone's looking to get involved in sideline event coverage, where would we start? How would we go about that?
Great question. So. There are a couple of ways, I guess. The easiest way would be to be at a program or an institution that has access to that. So just as use an example, as at USF, when my residents or even the med students want to do event coverage, we point them to USF Athletics and we say, hey, here's what's going on. Here's the names of the fellows that are fellows this year. They have the whole schedule for all of USF. We have University of Tampa. We have some high school teams. We have some minor league teams. We have some like there's plenty of coverage here, and we do that ourselves. But that's sort of an internal solution. If you're somewhere where you don't have that sort of access, the easiest thing is to just start Googling the like local teams. It's hard. It's gonna be very difficult to get in with a pro team, but in most cases at the collegiate level, maybe minor league sports, if you can figure out who the athletic trainer is, they can probably connect you with the team physician if they even have one. If it's at the high school level, ideally every high school has a team physician at least for Friday night football during the season. That's where probably the most pathology is. So, like here in Tampa, almost every school has a physician, whether they're there or not. But it's very easy to get connected with those if you just reach out to the folks who are, it's either the athletic trainer at the high school or like some of the models are there. All the trainers are employed by like a private physical therapy group or some private group who staffs them and sort of uses it as a way to collect patients. But I think reaching out to the people who are either covering it as the trainer or covering it as the physician is the best way. And that goes also for like event coverage too, right? If you look up Kona or whatever, you can reach out to those folks and then say, hey, can I get on the list to cover Kona in a few years, which is this, big triathlon in Hawaii. But anywhere in the country, there's these events and you just have to reach out to the people who are in charge. And the answer, in my experience, is almost universally yes. I wouldn't, you may not be able to get paid to fly there or hotel paid. Those things may be on you, but in terms of being able to be involved, usually not an issue at all.
Yeah, excellent. So don't expect to start at the top at a pro team, but
Correct.
first start with your institution, then go through your other contacts, then use good old Dr. Google.
Yep, Dr. Google, he's our best friend for sure.
I
Well,
don't know
now it's
about best
Dr.
friend.
Dr. Chat GPT now, right? I mean, the world is changing.
The world is changing. However, whenever you Google something, it gives you an AI summary. So I feel like it's the
It's,
same thing anyway.
yeah, yeah. I don't know which one's better either.
All right. Well, talk about some of your advocacy initiatives. So, a big theme is recognizing EM within this section, or the broader sports medicine community. And then, what clinical practices are you creating or contributing to right now?
So starting with advocacy, that can mean a lot of things. As an example of like a way that not me explicitly, but some of the EM docs in the past have advocated for sports medicine in general is like the physicians who are covering these pro teams or even college teams are crossing state lines where in states where they're not licensed. And so sometimes they're running into issues about what they could prescribe, especially controlled substances. And so now that was brought to the federal legislature and the NCAA put forth a statement, and they were able to basically pass a law that says you can get temporary sort of licenses with your professional team as you travel around the country, which sort of makes that process smoother so you don't have team physicians freaking out about treating their patient with a femur fracture or something as they're leaving the hospital. In terms of advocating for EM, the biggest thing is just showing up essentially, right? Whether that's at ACEP or AIM-SSM or for the teams in your community and being available. So like one thing that we do here, like today, for example, one of the family medicine physicians sent out an email saying that he needs help with doing pre-participation physicals for one of the smaller colleges that we cover here in Tampa. And I immediately forwarded that to my residents and it's like, hey, you got Dr. Murray needs help. Here are the dates. This is helpful to support our sports medicine section, and it will look good on your application for your fellowship. So hopefully a couple of the residents will go to each of those days and sort of advocate, if you will, while actually doing PPEs for this college. And then more at the national level, right? It's sort of like getting involved, right? So being a sports med section chair, we have a counselor, we have a vice chair, we have all these other roles at AIM-SSM, which is, I would say, more prominent when it comes to sports medicine specifically. Having some EM folks on the board of directors, and now Dr. Burkhoff's going to be the president of AIM-SSM in a few years. Like that's probably the best form of advocacy we could have at the national level, and there are people doing that, and that's amazing. And of course, there are other groups too, right? SAEM. There's something called the American College of Sports Medicine, which is more sort of comprehensive. It's not just physicians. It has like athletic trainers and sports psychology and physical therapy. But having a role there, there's people that have a sort of national presence there. And yeah, those are the big ways to advocate. For your other question was about clinical practice.
Mhm.
Yeah, it varies so much from institution to institution. So At UF Jacksonville, I basically got hired on and just had zero point 0.2 FTE or 8 days a week, immediately parked into the Department of Orthopedic Surgery, practicing sort of non-surgical orthopedics. And that was sort of seamless. And if I had stayed there, I could have gone up to eight or sorry, I could go up to like 12 or 16 hours a week if I had wanted to. Like there, and that's seamless because the two chairs basically just had an agreement. Here at USF, we have a different problem, which is sort of a geographic footprint. So the sports medicine clinic here is on campus. It's fantastic, but Tampa's a big city, and some people aren't willing to drive that far. So, like, what I'm trying to do with the family medicine chair is I pulled a bunch of data about like where the urgent cares are sending their MSK patients, where the primary care groups are sending their patients, and where our ER follow-ups are going, and most of them are not going to our group. And so I sort of proved that to my chair and the family medicine chair. They bring it to hospital leadership and they say, "Hey, here's a proof that our leakage is extraordinarily high." And then you can sort of quantify that based on the payer mix and say we're losing millions of dollars, and these people are leaving our ecosystem. And so that is an example of how we're going to expand our clinical sort of footprint. And then in terms of like the clinical mix, there's four of us that are EM sports here. We have a sports med clinic at the student health that we've built up over the last 2 years. So that's kind of been a cool project. We initially came on to help out with urgent care, but the student health medical director, who's a pediatrician, was like very open to us adding on sports, and we've done that. We've gone from half a day to 4 half a days now, and probably will add a fifth half day next year. And that's fantastic for the student body because they basically get treated for free at student health. So it's like basically a way for them to get free access to orthopedic care. And you can imagine a lot of 18 to 22-year-olds are getting injured playing sports and doing silly things on the weekends. And so we built that up, and then we're sort of helping family medicine build up their clinical footprint so that we can have sports clinic time through them. I have clinic right now, and we're going to build out some more so that everybody can have some clinic time. And then the goal is to just everybody to find their sort of balance of what they want in terms of EM and sports as we build out our practice.
Well, sounds like great success growing the specialty both within your institution and kind of ways to grow the specialty within the rest of the institutions as well.
Yeah, it's been it's and it's a we went from nothing to quite a bit in roughly 2 years, and with the addition of the fellowship and everything else, it's a very optimistic time for us to be here. So it's been very fruitful.
So lots of great ways to get involved in the specialty and in the section. You can do some committee work, get involved in the mentorship program, both virtually and then in person, coming to the national meeting, attending the section meeting and getting involved in your niche, looking and exploring the specialty so that you can do more for these patients than rest, ice compression, and elevation.
Yeah, it's a little more nuanced than that. Although that is an easy answer, there's more to it than that. Yeah.
What advice would you give an early career physician looking to get involved in the section and the specialty?
I would say this is really for anything, not just sports, right? Because we're all early career physicians. We come out of residency and we're like, hey, what do we do next, right? The answer is is to find a mentor, right? And that mentor could be a sports person. It could be somebody in your department that you look up to, right? If you're interested in research, find somebody who does research. And so for sports, I guess specifically, it's having a mentor either as you're going through fellowship and job hunting and knowing where you're going to land, getting advice about negotiating your contract, how to like negotiate some of the things that you can as far as what your practice looks like. Are they going to buy an ultrasound for your clinic? Like there are things that you can negotiate even coming out of fellowship that you may not realize. Sometimes the salary is the hard part, but there are other things. Can you negotiate protected time, et cetera? So having somebody who's done that before and has had these conversations with their leadership or is now the leader can provide you a lot of experience that's useful in the first few years of your career. And the other thing I think is just goal setting, right? So somebody's coming out of fellowship or they're entering fellowship and thinking about what's next. Do you want to do academics? Do you want to do private practice? Do you want to do all sports or all emergency medicine, or do you want to do a little bit of both? I think, which is what most people want, at least earlier in their career, and and then figure out how you're going to do that. There are people who do it in private practice. It is definitely doable. It gets a little tricky, but it is an option. And then in academics, whether you choose to be an academician or just work at a university and not necessarily like have a core teaching responsibility, is you can still do both that way too, I think. So finding a mentor and having some goals is probably would be my answer for somebody who's just coming out of fellowship and looking to sort of figure out the next steps.
Well, excellent.
Mhm.
So this has been the sports medicine section. Dr. Kiel, thank you so much for being here with me today. I want to end on a fun note. What is the craziest injury you've seen, or just look at the coolest thing that you've seen on the sidelines?
My answer to that question is actually when I was a fellow, it's kind of not an exciting story, but it's funny to me, is one of the backup quarterback at this school, don't want to be too specific, but had a seizure on the sideline. He wasn't playing, he hadn't been hit, like there was no injury. This was his first seizure, is what it turned out. And he happened to be standing right next to me. So I was on top of him immediately and I just rolled him and let him seize. Like that's all you can do, right? And we happened to have medics there and they came over. By the time they arrived, he'd already broken. This was probably 30 or 60 seconds. I don't know. And then the funny part is all of the other primary care sports medicine physicians, none of them who are ER trained, come running over at full speed, screaming about airway, screaming about oxygen. They look very panicked and flustered with the best of intentions. And I was like, guys, it's okay. I got it. He's already broken. We're just gonna, get a set of vitals and we'll take him to the hospital. And he was fine. But it was just sort of like I was in the right place at the right time. I'm sure he would have had the same outcome, but it was just interesting to see some of the non-EM trained folks sort of have a very, I don't know, dramatized reaction to what we sort of consider a day-to-day part of our job.
Emergency medicine at its finest.
Yeah,
There's
exactly.
only two places you can have a seizure and have people not freak out, the emergency room or the neurologist office,
Yeah,
not the sidelines.
exactly. Yep, everybody freaked out. That's exactly what happened.
All right. Well, thank you so much for doing what you do, advancing the specialty, advancing the section. Sounds like some great work both in your community and institution, as well as nationally. So thank you so much again for being here with me today.
Yeah, Dr. Barr, thanks for having me, and it's a pleasure to be here. Thanks for letting me ramble for a few minutes.